Lindsay. I'm an emergency medicine clinical pharmacist, and these are some interventions that I tried to make that were not accepted by the providers, and this is how I handled it. I walked into work to a patient having received 100 milligrams of IV Benadryl in about a 5-hour period. I had an NP order 25 more milligrams of IV Benadryl on this patient, and I messaged them and said, hey, this patient has already received 100 milligrams from this time to this time. This is not appropriate right now. I checked that the patient was not having an anaphylactic reaction. They were not having any reaction. Actually, they were just complaining of some itching due to an EKG lead. The provider said this is appropriate, 25 more milligrams is fine. And so I did actually go over them and go to their attending and let them know what had happened. And the attending said, absolutely not. Thank you for bringing this to my attention. I very rarely go to an attending, but this was a time where patient safety really did indicate for it. And I had tried to advocate for the patient who was very sleepy, had also received pain medication, and I didn't want them to get any more sedated than they needed to. Also didn't need to overdose on anticholinergics. I come in for a dog bite. It was a very superficial, very clean wound. They received the rabies vaccine, 1 dose of oral Augmentin. They were actually found to be in hypertensive urgency, so they were admitted. Besides their hypertension, their vitals looked good, their Y count, nothing was up, their labs looked great. They were ordered vancomycin, and so I reached out to the provider. I sent them the IDSA guidelines, Sanford guide. I said, hey, if you want something IV, we can use Unison instead of vancomycin, because orally we would be using Augmentin outpatient on this patient. And they replied, no, Lindsay, I want vancomycin. When I asked for further clarification, like, hey, what other bugs do you want covered? We can add some other coverage. Do you want azithromycin, something like that? And they said, no, I want vancomycin. And that's fine. I documented. We narrowed the next day. Had a PA order morphine on a patient who was end-stage renal disease on dialysis, and so we try to avoid morphine in patients without good renal function. They had already received 2 doses, and so I went and I was like, hey, can we please switch to Dilaudid due to these reasons? We talked about the nephrotoxicity, the different metabolites, and the provider said, no, I don't believe in Dilaudid. And I said, well, what do you mean you don't believe in it? Thinking like I could explain the med to him, and he just said, no, I don't believe in it. Don't ask me. They're getting morphine or nothing. And that is not fair to the patient. So I did go to their attending and say, hey, this is a situation. Do you mind if I just switch it to an equal dose of Dilaudid? And she said, yes, absolutely, please do that. Like I said, I very rarely go to the attending, but when patient safety is being compromised, you have to. You can't just sit there and say, okay, sure, let's give them morphine or nothing. That's not fair to the patient. Like I said, everyone is welcome to say no to my recommendations, but I do send evidence, guidelines, different data, and I document very well. None of these patients were ultimately hurt, but I did have to go to attendings multiple times, so that was a little different than what I usually have to do. But like I said, my providers make great decisions. Sometimes we just all need a little bit of help. And this is my job as a pharmacist, to make sure patients are getting the safest care possible.